Today, we are indeed extremely happy to have Dr. Esther here. Dr. Esther has completed her PhD in nutrition biochemistry and has also completed a master's in food and nutrition. She is at the Department of Clinical Nutrition and Dietetics. Dr. Esther again is a renowned personality and has several publications. She is often goes as a speaker at many international conferences. She has clinical nutrition experience over 15 years in the hospital. She's an RD with the Indian Dietetic Association. She was the highest marked PhD student in 2013. Congratulations for that, Dr. Esther. And she has been involved in the NABH quality audits and quality improvement projects over the past 5 years. She has also done some phenomenal work in oncology, nutrition, and healthcare. And we are indeed at BNA Life really happy to have you. And over to you for your session, Dr. Esther. I also like to say a big thank you to Dr. Geeta Dharmati, who's the secretary of the BNA Life organization, and she works very, very hard to put the entire program together and to kind of give it a flow. So thank you, Dr. Geeta, as well.
Thank you.
Over to you, Dr. Esther.
Yes. Thank you, Nazneen. Okay, so once again, thank you, Salome ma'am and Geeta ma'am. Thank you for having me over. I have connected from my hospital network, so I hope it works well for the next 1 hour. I have been associated with oncology for the last 7-8 years now, and I have learned a lot in the last few years because cancer is so much of an enigma and it never fails to teach us. When we kind of learn cancer nutrition in our MSCs or our master's program, what we learn is all about a high protein diet and nothing beyond that. And then we start working in these oncology centers, and then we realize that high protein diet itself is not just enough, and the challenges that we face in trying to meet this nutrition requirement of this set of patients. So today I'm going to be discussing about something that's been of interest for the last decade. There is not much of literature in this, but the world seems to be moving towards prehabilitation, and that is the reason why we thought that it might be useful for this forum to discuss about what is prehabilitation, how does nutrition fit into prehabilitation program, and when we work among cancer patients, how quickly can we start prehabilitating them. So that is what the next few slides will be about. And you can start raising hands or asking me questions if I'm going a little too fast, and if you need to understand certain concepts much more in detail. Next slide, Vishaka. Yes, so I'm sure all of us would have heard a term called rehabilitation. What we are going to discuss today is about prehabilitation. So what is prehabilitation? Prehabilitation is the process where there is care given right from the time of cancer diagnosis till the point of starting acute treatment. Okay, so this, so basically what we are saying is, as soon as cancer diagnosis is made and a definitive treatment protocol is started, we look at rehabilitating the patient so that whatever treatment protocol is started, the patient is better prepared for it. Now, prehabilitation includes physical and psychological assessments. In the coming slides, we will see all the pillars of prehabilitation. So it includes physical and psychological assessments. What we try to do is establish the baseline functional level, identify what impairments the patient is having, and then look at how best we can promote physical and psychological health so that the severity of these impairments or the incidence of these impairments can be controlled. Now, prehabilitation is like an extension of rehabilitation. So if I have to explain what rehabilitation is there is a problem that has occurred because of the disease or the treatment, and then we look at handling that problem. Prehabilitation starts before rehabilitation. Okay, so it's a model of care and rehabilitation, and this concept basically started when they realized, when you prepare soldiers for a combat in a war, how the soldiers not just have to be physically prepared, but also emotionally ready for what is ahead of them. So with that in mind, this concept of prehabilitation got started. Next slide, Vishaka. Okay, so this is just to explain about rehab. Rehab is more of an impairment response. So you know there is an impairment, and then you look at all the ways to address the impairment and help the patient recover from the impairment. Now, prehabilitation prepares for an anticipated impairment that can happen and can either delay or reduce the severity of the impairment. So there is multimodal teams involved in prehabilitation. Surgical prehabilitation is one of the first things that got studied because, we all know that there is this concept of ERAS. Surgical prehabilitation is an adaptation of ERAS where you look at physical and mental well-being of the patient so that the patient's functional capacity for the surgery is established. Next slide, Vishaka. Okay, so these are the pillars of prehabilitation. You have exercise, that is basically comes under physical therapy or physiotherapy. You have the psycho-oncology or the psychology or the mental health team that is involved in preparing or educating the patient in terms of what is cancer, because we start this at the time of diagnosis. What are the types of treatment protocols? What are the anticipated side effects? And how are the teams there to support them? You have nutrition that plays a very, very important role in rehabilitation alongside physiotherapy. So nutrition, we look at assessments, establishing the baselines, assessments, screening, and then development of the intervention protocols before the treatment starts. Look at correcting malnutrition before the treatment is started. And then how do you keep addressing the side effects that happen due to the cancer treatment? And the whole thing is to do a lot with education. So a lot of times there are nurse practitioners involved. There are also the social health workers who are involved in this model of prehabilitation. So prehabilitation is a process that aims to enhance the patient's physical and psychological function to help them support them before, during, and after surgery. Now, papers that have studied, I will be showing a whole lot of papers on prehabilitation. It basically shows that when you have a prehabilitation before a major surgery, it leads to faster recovery, better patient experiences, and a lot of saving for the healthcare system. Next slide, Vishaka. So this is just to expand on that. You look at functional exercise prescriptions, medical optimization. Nutritionally, we look at dietary modifications just to help you understand this a little better. If a patient comes to us with a head and neck cancer, patient has swallowing difficulty, dysphagia is there. Before the surgery itself is planned or before CT-RT is planned, then how do you deal with modifying the diet so that you can optimize the patient's nutrition status before the treatment is started? So that is just to help you understand what rehabilitation deals with. You have stress management. So yoga teams get involved, the mental health teams get involved. So there are relaxation strategies put in place so that the patient is better prepared mentally for the upcoming surgery or the treatment. Lifestyle choices, very important, especially for cases like head and neck cancers. Smoking and alcohol cessation, sleep hygiene, all of these things have to be educated before the treatment protocols have commenced. Next slide, yeah. So if you look at exercise program, so I will briefly touch upon these things, but I'll dwell more on nutrition because that's our core. But I will briefly touch upon exercise, psychology, and lifestyle changes, while I dwell a lot more on nutrition. So if you look at exercise program, most of us as dietitians, we only ask patients to go for a walk, okay? So in our practice, when we say, whenever we give out a diet chart, we tell them that go for a 20-minute walk, go for a 40-minute walk, try to be active at least 150 minutes in a week. But for cancer patients, just going for a walk might not really help. And that is what we need to understand, okay? So exercise programs basically are two types. You have aerobic exercises and then you have strength training. Now, why are we looking at strength training for cancer patients? It's not like, we want them to start competing for Mr. India or anything like that. But we have to understand something very, very important. Cancer is related with depletion of muscle mass, okay? So there is this condition called sarcopenia, which you will see to a great extent among cancer patients. Sarcopenia is nothing but depleted muscle mass. Now, while we try to pump the patient with high protein diet, we also have to not just look at the quantity of muscle, but also the quality of the muscle. And what really helps in building a patient's or retaining the patient's muscle mass is strength training. So there are two categories of exercise. One is aerobic exercise, which involves more of cardiovascular function, which again is very, very important because many of these patients go in for surgery and cardiorespiratory function has to be good. But while we're talking about that, we also look at strength training, which is advised about 2 to 3 days a week, where you're not, you're only focused on resistance exercises, focused to improve certain muscle groups and prevent depletion of the muscle mass. Okay. Next slide, Vishaka. Okay, so I'll dwell a little more on this because that's our subject. So nutrition management. Now we need to understand that about 55%, that is half of the patients who are coming in for surgery in a cancer setting, half of them are already malnourished at the time of admission. Okay, now because of the surgical stress and the long duration of the treatment protocols, this degree of malnutrition will worsen. Now, malnutrition and sarcopenia are very key preoperative risk factors. So we all know that if a patient is malnourished and you're taking up the patient for surgery, the surgical outcomes are going to be poor. Now, sarcopenia again has been studied extensively in cancer setting, and we know that patients who are sarcopenic, I will show slides on that. Patients who are sarcopenic actually have very poor post-operative outcomes and are linked with a higher rate of mortality. Now, what is sarcopenia? As I told you earlier, it is depleted muscle mass. So if you know what your muscle mass is and whether it is in the normal range, and is the patient's muscle mass getting depleted over the period of time, then that will become an indicator of sarcopenia. Now, if the patient is identified as malnourished, then we start off nutrition supplementation as oral nutrition support or enteral nutrition. Food fortification is also started up within the short frame of time that we have before the patient is taken up for surgery or active treatment. Okay. Now, prehabilitation programs generally are about 2 to 6 weeks before the treatment. So we have a short frame of time where we can build the patient up, work alongside multiple teams so that the patient's outcome of the surgery or the active treatment is better. Next slide, Vishaka. Okay, so yeah, so these are I've just tried to put up the different types of screening tools that we use. So I'll elaborate on it because I'm not very sure how many of you are actually practicing in a hospital and what tools are being used. But just to elaborate on it, you have MUST, which is Malnutrition Universal Screening Tool, the simplest of the lot. It has 5 questions. And it helps you to categorize the patient, whether the patient is well nourished, nutritionally at risk, or malnourished. Then you have NRS, and very commonly that we use, which is SGA, which is Subjective Global Assessment. Subjective Global Assessment is patient generated or something that you yourself can fill. Screening tools have to be simple. They have to be validated. They have to be something that even a nurse can fill or a patient themselves can fill it up. And most of the screening tools are either numerically or alphabetically classified. The end of what the result that you get out of a screening tool is that you want the patient to know, or rather you would want to know whether the patient is well nourished, nutritionally at risk, or malnourished. So those are the 3 things that you look at. Next slide. Okay, now based on the screening that is done, you look for nutrition assessment. Now, nutrition assessment is where you go detailed. Now, generally, internationally, and in a certain centers in India, the screening is always done by the nursing team or a junior medical team. Okay, so screening is generally done by them. They identify the patient as nutritionally at risk or malnourished. And then the patient is taken up by the nutritionist. Now, when the nutritionist gets involved, what she does is detailed nutrition assessment. Now, nutrition assessment is basically anthropometrics. because you're dealing with cancer patients, you have to understand that we look at muscle mass. So just weight is not enough. We might have to go beyond the weight and look at the muscle mass and the fat mass. So body composition analysis becomes important. So most cancer centers, the nutrition department has a body composition analyzer, a simple one or a more advanced ones. But it basically helps the nutritionist to understand how the weight is categorized into muscle mass and fat mass. Now that will help the nutritionist to understand what is the baseline muscle mass and then build the patient up. Now, apart from anthropometrics, we also look at biochemical parameters. If the patient is taken up for surgery, 100% we look at serum albumin, because albumin becomes a marker for surgical outcomes. We also look at LFTs, that is liver function tests. We look at kidney function tests. We look at heart function. We see whether the patient is in a fluid overload state. All of those things are things that we look at biochemically and clinically. The fourth important thing that we look at in a detailed nutrition assessment is dietary history. Now, why is that important for cancer patients? Is simple, because when the patient is presented to us, the patient might have already lost quite a bit of weight, like an esophageal cancer. At time of presentation, the patient would have already depleted 5% to 7% of his usual body weight. And because of the stricture or because of the medical condition, the intake of the patient for the last few weeks would have been very, very poor. Now, at this stage, if I don't record what the patient has normally been eating for the last few weeks, and aggressively plan nutrition therapy, the patient is going to go into a condition called refeeding syndrome or might have electrolyte imbalances. So nutrition intake in the last few weeks at the time of presentation of a cancer patient is very, very important. So we are looking at two things that we have to record. One is about the dietary history. The second is what was the patient's usual body weight and what is the patient's current body weight? Because as I mentioned, one of the factors that would have led to the diagnosis of a cancer patient itself would be weight loss. Okay, so understand what was the patient's usual body weight, what is the patient's current body weight. All your nutrient calculations go by this difference. Then, of course, we come to the third point as listed here, where you look at what is the total energy requirement of the patient and also what are the food options available and how do you meet the energy requirement of the patient. Look at macros, so look at how much protein requirement would be and how do you aim to meet the protein requirement. Now, we follow SPEN guidelines. In India, we tend to follow, most of us follow SPEN guidelines, which advocates about 1.2 to 1.5 gram per kg body weight. Now, this is adjusted body weight for patients who are obese, but otherwise we take the current body weight and calculate as 1.2 to 1.5 gram per kg body weight. There's a very recent paper published called the PRIME study. You can write it down. It's called PRIME study, where it talks about, compares protein intake of 1 gram per kg body weight and protein intake of 2 gram per kg body weight in colorectal cancer patients, just to see how the muscle mass is preserved. And it is interesting finding. So you will get the abstract online. Patients who were advised on 1 gram per kg body weight, they ended up taking about 1.2 gram per kg body weight. And patients who were advised 2 grams per kg body weight ended up taking about 1.6 grams per kg body weight. So it's a difference about 0.4 gram per kg body weight in protein intake. It was a 12-week study, colorectal cancer patients. And what they found was that when your protein intake is high, the muscle preservation is better throughout the cancer treatment. So very interesting study. So that is how it is. So when we look at proteins, we don't look at 0.8 grams. We don't look at 1. We aim for about 1.2 to 1.5 grams per kg body weight. We have to maintain the calorie requirements while we look at regularity of the bowel movement and glycemic control. Patients, while we plan the macronutrients, we also look at micronutrient planning because, as I mentioned, patient might be in a starvation mode at the time of presentation itself. So micronutrient deficiencies also might be evident and that correction happens alongside. So this is about nutrition intervention in a prehabilitation program. Just to summarize whatever was discussed in that slide, we look at the percentage weight lost, we look at what is the current body weight and plan the nutrients based on it. We look at the muscle mass. Just looking at weight is not enough. Try to do body composition analysis. We look at how has the patient been eating in the last few weeks before coming to us, and we start low and build up gradually. We have a short frame to build the patient up. So while we look at aggressive feeding, we don't want the patients getting into complications. Okay. So moving on to the next slide. Yeah, so this is a very interesting study again, where they looked at sarcopenia, which is depleted muscle mass, to be linked with mortality. Okay, so we'll never really think that, okay, if you have low muscle mass, a patient can actually end up having poor, or higher mortality. You'll never really think that, but this is a paper which actually shows that. So this is a paper which studied 1,326 patients undergoing hepatobiliary, pancreatic, and colorectal surgeries. So they are basically surgeries of the GI system. So you understand that GI system surgeries, patients are already having a high risk of malnutrition. Now, sarcopenia was defined as psoas density, and it was done in a preoperative setting, and patients were followed up to see. It is a retrospective study, so they looked at the psoas density, that is the muscle mass, and linked it to the outcomes of the patient. So sarcopenia was associated with postoperative complications and very significantly associated with 1-year mortality after GI surgeries in cancer patients. So if a patient is sarcopenic and the patient is going in for a major GI surgery, please understand that the outcomes can be poor. So prehabilitation looks at correcting these so that the patient's outcomes can be better. Next slide. Okay, so that was about nutrition. So I have briefly touched about exercise. I have touched a little bit more on nutrition. To just talk about stress and psychology, now we kind of understood how important mental health is to all of us, especially during the COVID times. Okay, so this aspect of mental health, anxiety, dealing with depression, all of this came to a lot of highlights in the COVID time. But in cancer patients, we have to understand something deeper. One is, cancer patient or cancer treatment is long, it is prolonged, it is not something which can be done in 1 week's time. From the time of cancer diagnosis, the patient is there with you for a period of about 6 months, can go up to years, where you are monitoring the patient's overall nutrition status and health. Different treatment modalities start. It's not like it's just surgery and the patient is out of it. There are a lot of times patient is diagnosed, then we start with neoadjuvant chemotherapy, then surgery, then goes on to adjuvant chemotherapy, adjuvant radiation therapy. There is role of immunotherapy. So different modalities of treatment are started and continued. So there can be a lot of stress that the patient undergoes because of the different treatments, because of the side effects, and a lot of fatigue that the patient experiences. Now, why is it that as a nutritionist, this is important? Now, for a simple reason, if a patient is depressed, it is very difficult for you to feed the patient. Okay, so if I have to meet, say, 1.2 gram per kg body weight of proteins, and if I have to meet, say, about 30 calorie per kg body weight, say around 2000 calories, if I have to feed a patient that much, the patient has to eat modified, texture modified food, and has to eat might have to have supplements, might have to eat frequently. Now, if a patient is anxious or depressed, 50% of my effort is gone in that itself, because I cannot feed the patient. Patient is not willing to eat. So that is where the role of mental health team comes in. So while we are looking at aggressively feeding the patient, educating the patient about the upcoming treatment protocols and preparing them for what lies ahead has to go alongside. And we can't really work in silos. It is very important for nutritionists to partner with physiotherapists, to partner with psychologists, to partner with nurse practitioners, so that we can kind of give a holistic care for cancer patients. Next slide, Vishakha. Okay, so moving on to lifestyle habits. So we know lifestyle habits like smoking, alcohol is linked to bad outcomes. But what do papers say about cessations before a surgery for cancer? Next slide. So this was one paper which looked at smoking cessation in gastric cancer surgeries. So preoperative smoking cessation for at least 2 weeks will help in reduction of postoperative cancers. Now, because we are healthcare professionals, we might think that as soon as cancer diagnosis is made, patients automatically will give up smoking and alcohol. But in practicality, that really doesn't happen. There can be two ways patients can look at. Cancer outcome is going to be poor, so let me drink and smoke as much as I can. Or they might not even know that smoking and alcohol can actually worsen their outcomes. Okay. So it is a very small percentage. We also should understand as healthcare professionals that smoking and alcohol is an addiction, and patients deal with this for over many decades, and giving up something just soon after diagnosis is very, very difficult. So there has to be many hospitals such as HCG and a whole lot of corporate cancer hospitals. You have cessation programs run in prehabilitation clinics. So smoking cessation protocols, de-addiction centers, all of this start in a prehabilitative setting before the patient is actively taken up for surgery. And that actually really helps in reducing the post-operative outcomes, improving the cardiovascular and respiratory function. So this is one paper that will just help you understand that. You can make note of it. These are freely downloadable. If you can't get the full text, reach out to me. I will share it to you. Next slide. Okay, so from this slide onwards, what I'll be discussing about will be papers. Okay, so what are papers that we have read about in prehabilitation? So if you look at this graph, it just talks about how many papers have actually come up in prehabilitation. And very interesting to note that it is only in the last decade that there has been increase in papers on prehabilitation. So prehabilitation has actually gained interest as a novel strategy to reduce treatment-related morbidity in patients undergoing cancer surgeries and cancer treatment. But the concept is very much at its infancy. We don't have too many papers. There are a lot of work. There's still a lot of work happening among multiple centers to really look at prehabilitation in improving the outcomes of cancer patients. Next slide. Okay, so this is a picture to help you understand how prehabilitation works. Okay, so you have diagnosis, and that is where prehabilitation starts. And then the treatment starts, and if you can see, there is a decline in overall health or quality of life of the patient. And then there is rehabilitation, which helps the patient to come back to living a life of recovery and living a life beyond cancer. Now, if there is no prehabilitation, you can see in the graph very clearly how the decline is, and even in recovery that it never really touches the baseline. Now, this is, of course, a graph that is not really proven by all the studies, but it is just a graph to help us understand that prehabilitation has a role in the post-operative and post-treatment outcomes, and it empowers the patients to have better resilience to the treatment and improve the long-term health. As I mentioned, prehabilitation is about 2 to 6 weeks before the treatment protocol, so we don't have much time. And one of the greatest challenges that I would say, I mean, if I have to say in India, is the time frame that we have before treatment actually starts to intervene and stabilize the patient. But if we are able to study that and bridge the gaps, I'm sure, you know, in terms of patient outcomes, it will be a whole lot, or the patient experience itself, it will be a whole lot different. So looking at papers, so I'm going to present a few good papers that that have kind of studied prehabilitation and looked at different outcomes. So this paper is a review article on prehabilitation in modern colorectal cancer surgery. Now, prehabilitation is still on an experimental treatment. We really don't have it as a prehabilitation protocol established in different hospitals. There are two types of regimens. One is unimodal, which is done in most hospitals like ours, where you see that you have nutritionists coming and giving nutrition therapy, you have physiotherapy giving physical therapy regimens. Then you have all unimodal interventions. And then you have multimodal, where people come together, different teams come together and then give a prehabilitation program to optimize the nutrition status and promote the psychological resilience. Now, larger scale benefits such as improvement in nutrition status, physical performance, also quality of life, or even reduction in lower post-operative morbidity, all of these have been documented. But how efficient is it in terms of improving the long-term effects? We are still studying about it. Next slide. Okay, so this is about prehabilitation in head and neck cancers. So in head and neck cancers, there are two types where we looked at prehabilitation as part of rehabilitation program. So preventive exercises are started before acute cancer treatment. And the second type is, of course, 2/3 of it is just part of rehabilitation program. Now, head and neck cancers, you should understand that rehabilitation program is very, very robust in most hospitals. Why? Because head and neck cancers, they have severe dysphagia, they have the role of a speech swallow therapist becomes very important. The role of a physiotherapist becomes very important. So there is a very robust rehabilitation program in many hospitals for dealing with head and neck cancers. So as a part of rehabilitation program, rehabilitation is taken in, and most of the studies have looked at that. And 1/3 of it has looked at how is it that if you look at preventive protocols prior to starting the acute cancer treatment. Next slide. Now, prehabilitation before surgery, is it for all the patients? Is it like one regimen fit for all the patients? Next slide. Okay, so this is to elaborate what I had mentioned. So you have unimodal exercises of prehabilitation, where you look at aerobic and muscular strength training in major surgical patients. Now, what that has shown is that it increases endurance, improves objective markers of physical stress, reduces weight gain, improves muscle strength, which is what we want, reduces fatigue and length of hospital stay, or length of overall length of stay. Now, over here, I would like to highlight on this word fatigue. Okay. Fatigue is a very common symptom. For people, for lay people, fatigue is equivalent to tiredness. And when a cancer patient comes to you and says that, patient is feeling tired, it is something that is taken so default that we don't really, we don't realize that it impacts their day-to-day activities to a great extent. Okay. Now, cancer-related fatigue itself has been studied extensively. Cancer-related fatigue is related to the chemotherapy regimens. It is related to the cancer treatment. It is related because due to the tumor itself producing so many different non-nutritive and hormonal-like factors. But fatigue is a symptom, and it is something that impacts the quality of life of cancer patients. And if there are interventions to either reduce the severity of fatigue or to reduce the incidence of fatigue, it is something that's great for in terms of patient experience. So exercise and nutrition especially in terms of omega-3 fatty acids and high protein diets, all of this play a very important role in dealing with fatigue. So this is a paper where we look at unimodal exercise rehabilitation has shown to help in reduction of fatigue. Then you have unimodal nutrition rehabilitation, where you have given only nutrition intervention. Now, in nutrition intervention, we know perioperatively we give nutrition intervention, and it is linked to better outcomes. Now, nutrition intervention, we either give it as oral supplements, or we give it as enteral nutrition, or we give it as TPN. Oral nutrition support has been linked with about 21% of hospital length of stay, and that has actually shown to reduce the cost. So a lot of us, we look at using more of kitchen-based feeds because we want to look at cost. but there is a specific role of oral nutrition supplements in meeting your protein and energy requirement, especially for cancer patients. And this is one paper where it shows that it actually benefits the patient in reduction of cost. Then, of course, you have multimodal prehabilitation, where you have nutrition given at one side, you have exercise given at one side, and that actually decrease the length of hospital stay in patients undergoing colorectal cancers. So there is a role of each of it. There is a role of mental health, there is a role of exercise, there is a role of nutrition, and whether it is given individually or it is collectively given. Okay, there is one question on chat. LOS is length of hospital stay. Okay. Next slide. Okay, so if you look at this picture, it basically, it's again, it's just to help you understand what prehabilitation is all about. So prehabilitation basically helps you to prepare the patient. It helps the patient get prepared for the surgery and the treatment. It happens in the pre-cancer treatment period. Then it builds the patient up throughout the treatment and also moves on till the completion or during the survivorship. So prehabilitation has been associated to reduce the length of hospital stay, but in this study, which is listed down, the reference is given down, they did not find effect on post-operative complications or mortality rates. And therefore, they recommend prehabilitation to accelerate the recovery from cancer surgery. So very similar to ERAS protocol. So if you know, ERAS protocol is enhanced recovery after surgery, where they look at giving nutrition intervention alongside other variables, and they look at improving the patient outcome after the surgery. So prehabilitation is part of that kind of ERAS protocol. So that is what this paper highlights, that impact of prehabilitation in hepatobiliary, colorectal, and upper GI cancers is more recommended to accelerate the recovery after surgery rather than just to improve the mortality rates or the functional capacity. Next slide. This is about prehabilitation, potential benefits in types of cancer surgeries. So if you look at colorectal, prostate, lung, breast, pancreatic, urological, and gynecological cancers, it has been shown that role of prehabilitation has helped in reduction of depression, improved emotional functions. There are fewer complications. There is decrease in self-reported and trait anxiety. And serum albumin levels were more likely to be abnormal in the non-prehabilitation cohort. But of course, further research is needed because, as I said, there are very few papers that are dealing with prehabilitation, but the role seems to be promising. And I think it is time that many of us try to implement prehabilitation and see what the patient's outcome is going to be like. Next slide. Okay, so the next two studies are very interesting. Now, this is an extensive study that is done on exercise and nutrition prehabilitation in functional capacity in upper GI cancers, which is esophageal and gastric cancer surgeries. Now, in the intervention group, what was done is food-based dietary advice was given, whey protein supplement was started. Protein supplements met the requirement of 1.2 to 1.5 gram per kg body weight. And these supplements, if required, were consumed every morning after breakfast and immediately after the exercise on training days. Control group followed the ERAS protocol guidelines, and they did not receive any specific intervention before the surgery. So there were two groups, intervention and control group. There were 26 patients in the prehab group and 25 in the control group. And they found that in this study, they found that prehabilitation significantly improved the functional capacity before and after the surgery. Next slide. This is another paper which was published in JAMA Surgery, which again was done in about multimodal prehabilitation done in colorectal cancer surgeries. Very interesting paper again. 7 hospitals from 7 different countries and about 123 multimodal prehabilitation papers were done. 251 patients were randomized and analyzed. Now, if you look at the findings, what you will see is multimodal prehabilitation actually reduces the post-operative complications compared to the standard of care. So these two papers, both of which references are given, you can take it later, but read it to understand how prehabilitation actually impacts the post-operative outcomes. Next slide. This is about breast cancer. So breast cancer, because of the extent of breast cancer patients that we see, what we realize is that breast cancer patients come in, they undergo neoadjuvant chemotherapy, and then they have the breast cancer surgery. And then we really don't look at what could be the extent. Head and neck cancers, GI cancers, all of us know that nutrition gets compromised and they are more debilitating. But breast cancer, we all know that patients might be obese and, maybe nutrition really doesn't have, work. But this is a paper, 2022 paper, which shows that prehabilitation programs actually help in reducing the anxiety, stress, insomnia scores in breast cancer. And we have to understand one thing, that breast cancer patients, because of the chemotherapy regimens, the fatigue scores of breast cancer patients is really, really high. So while they might present you as obese, understand that their muscle mass might still be low, and the treatment outcomes in terms of fatigue and treatment tolerance in terms of the chemo regimens, a lot depends on the type of nutrition advice that you give and physical activity. Next slide. Okay, so this is just about what is it that we give. Do you have physical therapy, nutrition support, and psychological preparation? Next slide. So that was what was given in this paper, which talks about major abdominal surgery, the feasibility protocol, and they found that it is actually feasible. There were no cardiovascular incidences occurred during prehabilitation. 6-minute walk test that we do to understand how is one of the tests to look at frailty of sarcopenic patients. The 6-minute walk test actually significantly improved anxiety, depression, several quality of life parameters were improved. Post-operative 90-day mortality and morbidity was 3.4 and 48% respectively in prehabilitation group. The median hospital length of stay and the ICU length of stay were 14 and 6 days respectively. Only 19 patients were readmitted. So post-operative readmission rates was lesser in the prehab group. Next slide. I'll be just concluding now. So yeah, so if I have to just conclude on what is prehabilitation, if I have to just give it in my own words, understand that prehabilitation is a concept that has really been promising, but still a lot of work is still going on. It has been up for the last few years, a decade probably. So we don't really have it as a protocol in many hospitals, but it is a role that we can look at in terms of improving patient outcomes. A lot of papers have shown for sure that prehabilitation has improved functional capacity, both in the preoperative and postoperative period. Complication rates and length of hospital stay has been shown to be reduced in certain papers. Nutrition therapy is very, very important, a very crucial component of a prehabilitation program, but studies are heterogeneous in terms of what kind of nutrition therapy has been provided. The evidence definitely at this stage ranges from moderate to very low, but that is mainly because of inconsistency in terms of the data. Okay, so I'm open to answer any of your questions, and I will start with what is coming in from the chat, and then if you want to just ask as well, you can just unmute yourself and ask. So I have one question: how do you encourage patients for strength training when they are coming from small village only for treatment? Yeah, so strength training, partner with your physiotherapy or physical team. See, strength training is not about lifting weights. We need to understand that it is not carrying dumbbells or barbells. Strength training can be something that they are just doing it routinely in their village as well, but it's something that they have to incorporate in as part of their regimen. So discuss with the physical therapy team to understand what kind of strength training can be included for the people coming from village. We also have a lot of patients coming in from remote places. Physical therapy, face-to-face exercise schedules really help, but everyone knows that that is not possible for everyone. So even if they're coming from remote places, you can always give them a regimen that they can follow in terms of physical therapy. Now, the only reason why I wanted to highlight about strength training is we as nutritionists really believe in just walking. But in cancer patients, we have to understand that walking alone doesn't help. Okay, so you'll have to partner with a physical therapist to include some form of resistance training exercises so that whatever nutrition you're able to give actually helps in building the muscle. Thank you, ma'am. Sheila, ma'am, thanks for your words. The question is, sometimes the patients have no time to go through prehab. How do we deal with that? So that is one of the challenges that we deal with. Very, very true. Because as I said, most of our surgeons are in a big hurry to do the surgery. So from the time the patient is coming in with a diagnosis, within the next 3-4 days, the patient is taken up for surgery. However, as per this protocol, all cancer surgeries are elective surgeries. They are never emergency surgeries. Cancer surgeries are never emergency surgeries. So we do have a time frame. And if we are able to implement this like a protocol in the hospital, where patients are screened, and if the patient is screened and deemed as malnourished, then can they go through the nutritionist to build the patient up before the surgery. So at HCG, if I have to talk about my practice, a lot of challenges. I'm not saying we have it all, but even a 5 days or a 7-day intervention of helping the patient be built up before the surgery, and if I'm able to partner with the mental health team and also the physical therapy team, then what happens is the journey with the patient is long. So we actually start right at the time of diagnosis, which really helps in building the relationship, and the patient is more open to whatever changes we make in terms of the diet, even post-operatively. So that is, yes, ma'am.
Thank you, Esther. Excellent answer. In continuation to what I just asked, does it also increase the cost for a patient? Because as it is, cancer treatment is quite expensive. And if you're giving, a couple of weeks extra for prehab program, how much cost does it increase for the patient?
Not significant, ma'am. So what we do is a prehab protocol, or rather, it comes as the initial payment happens, and then the follow-up sessions are all free till the time of treatment. So the next time the patient is actually billed is only at the time of admission in the hospital. And that is across board. I mean, it's not just for nutrition. It is also for mental health. It's also for physical therapy. So it's not like every time they come in for a session, they have to pay us. So it comes in like a package, which the patient pays at the initial time, and the same package continues till the time of admission.
Thank you. Thank you, Salome, for organizing a great program.
Thank you, Sheila, for joining and for
Thank you
your
for joining,
inputs.
ma'am.
Welcome to
Thank you.
BNA live session.
Thank you,
for
Salome.
your
Thanks, Geeta.
encouragement. Yeah.
Thank you, ma'am.
Okay,
Thank
there
you
is
for joining.
Ankita wants to ask the question. Can I
Yes,
take
Ankita.
Yeah, Ankita.
Yes.
Ma'am. Yes, ma'am. It's very nice to have you, ma'am. It's a
Thank
very
you.
learning session for me. And I just want to add one thing, ma'am, and asking also. The protein is play a very game changer in cancer patients because of the sarcopenia. They need very high protein, but protein is sometimes enhance the sulfur things in our body, and if cancer cell is fed on sulfur, so can I introduce the plant protein in their diet as well as the animal protein?
Yes. So proteins are always a combination of plant, animal. If a patient is a pure vegan, then yes, we don't use animal proteins of any kind. But there are a lot of options now in terms of supplements as well, right? From pea protein to plant-based protein to plant-based, lot of options. So we customize it basically, but 90% of the patients can be on a combination of plant and animal based. What we look at is high biological value proteins because we are looking at maintaining muscle mass, muscle mass needs branch chain amino acids. Branch chain amino acids are found only in high biological value proteins. So we look at that link and then we give the kind of proteins. But
Thank
we
you.
have to understand one thing. Once cancer is diagnosed, cutting down sugar, cutting down sulfur, cutting down all these foods is not going to prevent cancer as such. A lot of times patients go aggressively on zero sugar diet thinking that they can reverse cancer. It doesn't really help. Not that as nutritionists we give a lot of sugar in the diet, but it's not like we put them on a zero sugar diet, you know. So it is important for us to educate on what is evidence and make sure that we give the right kind of diet that the patient is able to tolerate. Yes.
Esther, I continue the question from there.
Yes.
There's a question from Tirtham Karji. I think the same, what you just spoke about protein. Apart
Yes.
from high protein diet, which would be helpful for cancer patients, do you have any supplementations or any kind of specific nutrients in this prehabilitation stage? So, an extension of a protein question here.
Yes. So there are a few things that have been studied in a prehabilitation program. One is we look at 1.2 to 1.5 gram per kg body weight. But having said that, we also look at whey-based proteins because whey protein is having a higher proportion of branch chain amino acids. We also look at omega-3 enriched because we want immunonutrients to go. So it's more of immuno enriched high protein diet that we look at in the prehabilitation program. We do use supplements. Cancer patients, 90% of the times we use supplements, but we don't. There are times when we wean off supplements just to make sure that the patient is able to tolerate natural feeds as well. But in the initial phase, like if I have to talk about the prehabilitation setting, and if the patient is having dysphagia or an esophageal stricture or any condition where the patient cannot meet the nutritional requirement and I have a short frame of time, then yes, I do rely on supplements.
Interesting. Suppose, did you anytime encounter I think work in a super specialty hospital, but I think Salome ma'am also can talk about it. That these supplements, you're talking about meal replacement supplements, high protein supplements. But then there's a question from Tejaswita which says that in case of tube feedings and when supplements are not affordable, how did you plan the kitchen-based feed? And Salome ma'am, I think in your times it was mostly kitchen-based feed. Supplements just came in just 1 or 2 decades back. So, any inputs on planning of RT feeds, or you say no to kitchen feeds and push yourself to supplements? Over to both.
Ms. Geeta, Esther, you want to comment?
Yeah, yes, ma'am. So
Go
yeah,
ahead.
so see, we can have scenarios where we are not using supplements, where we meet the nutritional requirement or the protein requirement using kitchen-based feeds. But you have to understand that the patient has to have a good GI system to absorb all that we are planning through home-based feed. So there are times when I will use cashew nut paste, peanut butter paste. I will be using coconut milk. I will be using different forms of, kitchen-based modifications to make it calorie dense and protein dense. But in a setting where a patient has a compromised GI system, where I know that I can give less volume, but I have to kind of give it as more dense, then yes, for that period at least use supplements and then move back to kitchen-based feeds. Looking at affordability, currently there are a lot of insurance schemes that actually permit medical nutrition therapy that can be claimed. I'm not saying they can buy it under the insurance, but then they can get claimed. So a lot of cancer patients, they can claim the medical nutrition products under the scheme that they have, but it is not across board. But I think some things that help me is educating, saying that you need it for this period of time. It is to meet this requirement. And then I wean you off. And then I restart when I think I need to restart. Because it's not like the entire 6 months the patient needs to be on supplements. Or, suppose I have a breast cancer patient and the breast cancer patient is well nourished and is tolerating the therapies well, I don't really put them on supplements. They are on complete, kitchen-based diet. But if I have a breast cancer patient, but patient is having extreme fatigue and her intake is very low, is battling depression, then for that short frame of time, I do use supplements. So it's very individualized. As I said, cancer is a big enigma to all the oncologists. Nutritionists, we are still learning a lot.
But there is a pre-surgery drink also. Is that true? I'm
Yeah,
not
the
aware of
pre-carb
it.
drink.
And
Yes.
do you recommend it because it's very much in line with prehab? What
Yes,
you just
so
spoke about.
it is part of ERA's protocol where they give a a pre-carb drink that's mainly to reduce prolonged fasting. So earlier, many decades ago, it used to be like 12 hours fast or it used to be 24 hours fast before surgery. But currently, even if it is GI surgeries, the advice is minimal fasting. So even up to 2 hours before the surgery, the patient can have a dextrose or a 50-gram glucose drink. But that is actually under the purview of the anesthesiology team. We don't really get involved. ERA's protocol is part of the anesthesiology team, so they take care of this. Where I come in is on two levels. One is pre-surgically, nutritionally, if I have to stabilize the patient, then I have probably a week to 10 days to build the patient up before the surgery. The second place where I come in is early enteral feeding. So as soon as the surgery is done, within 24 to 48 hours, we need to start off enteral nutrition. So these are the two factors where, as a nutritionist, I come in. For the pre-carb load, we leave it to the anesthesiologist because most surgeries happen early morning, and patients have the last feed at around 10 p.m. and then the patient sleeps, and then early morning the patient is taken up for surgery. So we really don't have waking them up at 4 o'clock to just give one drink. We don't do that. Practically doesn't work.
Great. Thank you. I think a lot of questions coming in. I would move it to Salome ma'am to understand that we really take all of them, or they can ask you personally, because we've already exceeded our time to 5 minutes more. We started on time. Salome ma'am, over to you for the comments about.
I think we can mail the question to Esther, and we can put it on our website or even on our channel, so that those who are seeking the answers, we can definitely give them the answers. So thank you, Esther. I think you have really done a great job. And
Thank you, ma'am.
this was what we were looking at when we were doing inflammatory conditions and the prehab and rehab. As you said, it is only in the last decade it has come up, and we are having evidences. It's been really helpful for both the patients and the entire medical and multimodal team. This unique approach is, I think, we should have it in each hospital. So if I have to say, looking back in my practice, as early as 2006, we did start ERA's protocol in our setup when it initially came. And as you rightly said that, yes, 10 p.m. and early morning feed. So if early morning feed is not given, it is intraoperative what carbohydrate loading goes. And I think that really helped patients to recoup better and say prevent post-operative complications. As you rightly said, what we are missing is, yes, a protocol, that is one thing. And as a nutritionist, we are not very proactive when we are screening the patients early when they come in. Yes, when in my setup, because I was working in a government setup and we had a huge load of incoming patients, and sometimes we didn't have time for prehab or even sometimes for the rehab, but we did get references from our medical oncologist team, radio oncologist team, and oncologists to build up the patients. And though we were a charitable institute, government institution, I think we were able to give supplementation to those patients who need to build up. The sarcopenia aspect is a little later aspect, but to pre-surgery, perioperative patients, we did give them the supplements, oral nutrition supplements. And if I can tell you, as early as early 90 or late 80s, we had it here. Meeting with our nutraceuticals, and we did have in India those nutritional supplements. I think I was the one when they came into the Nestle, Novartis came into, and we were at least not, if nothing, the high protein supplements came in, and we were. But it was a challenging for us also. But if I tell you, we did have as a municipal hospital, I think, say, funds for these particular patients and for nutritional provision. So we could give them. Plus, I could also honestly say the company itself gave us lot of samples, and we had some charitable organizations, NGOs helping us, giving us whey protein and other protein. Some the Rotary Club people also. So we did have these supplements to feed our patients preoperatively and as early as we start the enteral nutrition. But kitchen-based feed was also the main forte, where we had patient didn't have to pay; it was free. So we did have 1.5 liter of milk and say 2 to 4 eggs sanctioned, and other nutritional resources which we could make a blended feed very hygienically, and in fact the dietitians, my interns, were preparing, and we were able to give it to our patients. I don't know the scenario for those people who have asked these questions, but I think with limited resources also you can do this. It's just a matter of how you are into this, how well you plan the aggressive nutrition therapy and the regimen for your patients. So I think we can do that if we really, as we say, where there is will, there is way. And we can provide nutrition for these patients, definitely, for those non-affording ones. Affording ones, yes, they can very well spend money on, but they don't want to, because the nutrition was neglected in those days, and even now people don't want to spend on nutrition and nutrition supplements, though they have good amount of. So that's what we need, a counseling. We really need to have a teamwork where we need to say, yes, I want to prevent so and so complications, and I want to give 1.52 grams of protein every day, at least for 10 days, 15 days, or a month. And that is what we really have to give. Do this with our patients, and develop a protocol for whichever institute you are working. For the participants who have joined in, who have problem, I'm addressing to their issues, and we can manage this. We also had Rajiv Gandhi scheme, where we were giving them, those who are orange ration card holders, a free of cost, the even parental nutrition in hospital was available, and enteral, of course, enteral, parental, and ONS. So I think that are things we can use, and really do much better work in the area of nutrition and feeding our patients for a better outcome. I think I will agree with me, Geeta, Nazneen, and
Mr. Gandhi, can we have your mic on mute? Thank you. Yeah, ma'am, absolutely well said. And I think you all belong to an era. Plus, I also have managed a lot of home feeds, kitchen feeds where priority supplements came in to chip in or fill in the blanks. But gradually we realized standardization for feeds was major challenge. Dietitians could make out 1 gram contribution of any particle. Even if I add 1 gram of sugar, also it will make up to plus 1 ml. So that calculations always messed. Two eggs are already 120 ml, and then I had to add 60 ml of milk, so the eggnog became. But I calculated for 100 ml of milk and then 2 eggs. So I think the calculations also went haywire. So standardization was a challenge there, and I'm sure all of us agree with it. And now the supplementation has come in. Most of the people who can afford it can pay for it any day that gives you a eucaloric or a hypercaloric feed. So thank you very much, ma'am. I think that makes a lot of impact here.
Thank you.
Thank you. Ma'am, should we close the session?
Yeah. If anyone wants to make any comment, Eileen or anybody else, you can unmute and make a comment, because this is an area where we are looking into and developing a protocol for both prehab and rehab, which is going to, in a long run, help our cancer patients.
Absolutely. Is Eileen there? Anybody who's practicing in this kind of area would like, yeah, Eileen, hello, welcome.
Hello, ma'am.
Good to you.
Congratulations for
Yes.
this program. Very nice. Yeah, actually, very pertinent topic because as of today, we are doing prehab here in our hospital, and when we do a good prehab program, we always find a very positive outcome. But I think what here is missing is, I think a lot of time is required for this, and most of us are we are rushing with so many things that sometimes we do neglect these prehab programs, and maybe sometimes means this is the what I'm trying to say is uh, you know as my experience that as a holding the department, because when I have to put in staff for a prehab program, I know the kind of pressures that they have, because they are kind of maybe having 10 patients at a time. They don't have the time enough of time to monitor and give for so many patients, and then sometimes we lose the control of that situation. So here, if you make a protocol that it has to be done in stepwise protocol like an algorithm, it will be followed. But if you just leave it to unknown, or just leave it to be done the way it has to be done, it things may get skipped off. So creating a protocol and making it will differ little with institution to institution, but overall, to make a protocol is a very good thing, and we can even publish that protocol.
Yes, rightly said. That's it. Should not be individual. It should be institutional protocol, or it should be through these guidelines protocols, which all India, pan India level we can follow it. I think Esther can do that, and we can all
Yeah, Esther, I think
follow.
we look up to you, Eileen, and
Yes.
you are actually working in a institution and working on these kind of patients. So
Yes.
that it helps pan India, most of the dietitians, because prehab itself is a new concept for many of us who've been joining. And then in prehab, what to do absolutely is unknown. Rehab, we all know. So looking forward for the leadership, or under leadership of Salomi ma'am, we'll try to put in this protocol of prehab.
I'll do anything to help you and to be a part of it and to assist in the prehab program.
We'll
It
take,
will be my pleasure.
Appreciate, Eileen. Thank you.
but I think we
Get
should,
back to you.
and then there is a line drawn up between the rehab and the prehab, and that's what we need.
Exactly. So we need to know the thin difference between prehab and rehab. And we need to sensitize it, because
Nazneen
not
is
many
also
doctors are
around.
sensitized.
So I think Nazneen was also wants to comment something.
Yeah, and
Stand up.
we have Arpita also raised hand, so she can also comment, and then Nazneen can comment. Arpita, you can speak.
Yes, ma'am. Ma'am, already I have asked the question in the chat
Your
box.
hand is raised.
Yeah.
Okay. Yeah,
Yes,
over to
ma'am.
you,
Am I
Nazneen.
audible, ma'am?
Because the time is up, we will get back to you, or we'll answer
I've mentioned that.
answer your questions. But if you have something very urgent, or you really want to put it, you can just take a.
Yes, ma'am. Yes, ma'am. It was.
Yeah, please go ahead.
So one of our patients, she is right now on FJ feed, 250 ml. We have been giving her peptamin and resource HP, ma'am. For 4 scoops, 4 scoops in 250 ml, and she has loose stools continuously. So what can be done, ma'am, in this case?
Arpita, can I speak to you on this? Because we will need a little more details before we comment on a forum like this.
Okay.
So you can take my number, and then we can connect offline, and
Okay,
then
sure, ma'am. Thank you so much. Yes, ma'am.
I will suggest, because there has to be certain details that I will need to see before I answer that.
Yes, ma'am. Yes, ma'am.
Yeah.
Thank you.
Okay.
Please.
Nazneen, over to you.
I
Ma'am,
think Dr. Esther, thank you so much for this phenomenal
ma'am,
session.
contact number.
The,
Where will I get it, ma'am?
We will send it to you.
I'm so
Arpita.
excited. The questions are just pouring in, and I think clearly shows that there is so much more interest, and you beautifully explained this entire presentation. So thank you so much for your presence, and we love to have more sessions from you as follow-up questions sessions. And thank you, audience, for being a great audience and for having so many questions. For all the friends who have missed us, you can go and catch these sessions live on the YouTube channel of BNA Live as well. We have all our recordings over there. Please like our pages so that you get regular updates for the same. And thank you, Salome ma'am, for providing this platform for everyone to learn. Thank you, Dr. Geeta, Dr. Esther. We had Sheila ma'am, Eileen, Ruby, and a whole lot of people joining across India. Thank you all for joining in. A big thank you to Mr. Nitin Gandhi, Alpesh, and Mr. Advait, and the entire Nutritionics team for backing us and enabling us to continue with this continuous education. Thank you all and have a fantastic day.
Thank you, Nazneen, at the end, to have been anchored the show so well. Thank you. You're a wonderful part of the team always. Thank you. Thank you, Salome. Thank you, everyone. Thank you, Esther.
Thank you all. Again.
Thanks, Esther. Bye.
See you all next.
Bye.
Bye.